In Chapter 9, we're going to be discussing cerebrospinal fluid analysis. This chapter in the textbook is pretty well written, so I want you to spend some quality time with the material in the textbook. Cerebrospinal fluid, or CSF, circulates in the brain and the spinal cord, where it provides nourishment and removes waste from the central nervous system. The CSF also supplies buoyancy. It suspends the brain in a fluid and also protects the brain from injury when jolted or hit. The brain produces roughly 500 mLs of CSF per day. The CSF is produced primarily 70% from secretions of the four ventricles of the brain by the choroid plexus. The ependymal cells that line the brain and spinal cord play a minor role in CSF production. The formation of CSF is described as a selective secretion from plasma formed in two steps. It's a filtered form of plasma that moves into the interstitial spaces and is guided by a difference in pressure. The fluid passes through epithelium cells, which act to prevent most substances from flowing freely into the CSF. So the epithelium cells are the ones that are selective in allowing certain components to go into the CSF and prevent other components from going into it. Because of the selective secretion, CSF has higher levels of sodium, chloride, and magnesium than does the plasma, and it will have lower concentrations of potassium, calcium, and protein than does the plasma. This picture illustrates the anatomy of the brain. So this is the cerebrospinal fluid pathway from formation to where then it circulates around the brain. So we have the lateral ventricles that the fluid then goes into foramen of Monro, and then it goes into a third ventricle. Why they don't list the first and second, just for curiosity purposes, I don't know, but the actual formation will occur in the third ventricle. Then it goes into the cerebral aqueduct, which then is transported to the fourth ventricle. Then it goes to the foramen of Luschka and Magendie, and then it goes into the subarachnoid space. Then after that, it will then go into the venous drainage system of the brain and flow around it. The brain and spinal cord are surrounded by three membranes called meninges. The dura mater is the outer layer next to the bone. The arachnoid mater is the middle layer, and it resembles a spider web. And the pia mater is the innermost layer adhering to the surface of neurotissues. And the brain tissue is broken down into white matter and gray matter. Cerebrospinal fluid forms, circulates, and is reabsorbed into the blood. And this is a dynamic process. The CSF is turned over 20 milliliters each hour. If reabsorption of the CSF process is blocked, it may build up, causing a condition called hydrocephalus. And you may have heard the term water on the brain, although it's not water, it's CSF. And this causes increased pressure in the brain. If this gets too severe, this may result in brain damage, intellectual and developmental disabilities, and if untreated, death. Normal adult volumes of CSF are in a range from 85 to 150 mLs, and that's not very much. Think of your 100 ml graduated cylinder. In the big picture, we look and see how big our head is. You wouldn't think that 150 mLs would do very much, but it does. There's a modulating interface between the blood and the CSF, and this is called the blood-brain barrier. And an example of this is the failure of some antibiotics given intravenously to enter the CSF. But the antibiotic will circulate freely in the blood, so it can penetrate all cells in the body. The chemical composition of CSF is closely regulated by the body, and only certain substances can cross the blood-brain barrier. resulting in differences in concentrations of electrolytes, proteins, and other solutes in the CSF versus what is present in the plasma. Changes in the chemical composition of CSF may assist in the diagnosis of diseases and conditions. I like this picture because it shows how the CSF flows into the subarachnoid space between the arachnoid mater and pia mater, where it bathes and protects the brain and the spinal cord. Cerebrospinal fluid is specifically collected for the diagnosis and treatment of disease. And if you look on page 246, I want you to go ahead and review the number of diseases and conditions that a doctor would order a lumbar puncture. It's collected by aseptic lumbar puncture in the third or fourth lumbar interspace with local anesthesia. It's then delivered to the laboratory immediately and to each department so that the testing can be performed stat. There are some infections that a patient will live or die within 24 hours if it's not diagnosed and immediately treated. So the picture on the left shows you where the needle goes in to the spinal, to the spaces, and then on the right it shows you the positions the patient is placed in for a lumbar puncture. They can either be laying down in a fetal position or sitting up with their backs rounded. I had a lumbar puncture, and unfortunately it took 3 times. One doctor did it twice, and then another doctor was successful. And it was not uncomfortable. I did not get local anesthesia. You feel pressure and a little poke like a venipuncture, and then I could feel the pop when the last doctor did get into the position where he needed to be to collect the CSF. I found this part of the procedure interesting as it was not done on me. And this involves taking an initial or opening pressure with a manometer that's attached to the spinal needle. So the needle is in place and they attach the manometer. A normal recumbent pressure is 50 to 180 millimeters of mercury. Closing pressure taking after collection of the sample should be 10 to 30 millimeters per mercury less. Both pressure values and amount collected are recorded, up to 20 mLs with normal pressure. If the CSF pressure is less than or greater than normal, you should only remove 1 to 2 mLs. So this procedure will determine how much fluid can be safely removed from the patient. The sample is collected into 3 sequentially labeled tubes. Tube 1 collected first will go to chemistry. Tube 2 delivered to micro, because we don't want it to be the first tube, because this reduces the chance of contamination with skin flora that would give a false positive culture. And tube 3 is delivered to hematology for cell counts, because it will be the least likely to be contaminated with blood from a traumatic draw. A traumatic draw is on the way in, they hit a vessel, so bleeding is occurring. It's not the blood was already present, but the blood is being introduced from piercing a vessel. The following tests are routinely performed on CSF: color and clarity, just like you would do with a urine, and the pressure during collection. Protein, glucose, cell count, the total number of cells present, and the differential cell count, the numbers of different types of cells present. Because as you've learned in hematology, lymphocytes will indicate a viral infection versus the segmented neutrophils would indicate a bacterial infection. Additional tests may be ordered based on the condition suspected. Normal CSF is absolutely clear and absolutely colorless, and it has a viscosity like water. In fact, when you look at the tube and you tilt it back and forth, your first impression is, oh my gosh, this is water in this tube. Increased amounts of fibrinogen, which is a blood clotting protein, can lead to the formation of clots, which indicate most commonly that this is a traumatic tap. And again, a traumatic tap is one in which a blood vessel was pierced on the way in, And so in addition to obtaining spinal fluid, you're going to get blood. Delicate clots may form a thin film or pellicle on the surface, and this can occur after refrigeration for 12 hours or more. So it's not something that you observed when you initially got the fluid. This was you put it in the refrigerator, and for some reason, perhaps additional testing needs to be done. You pull it out, and there's the clot. The least common reasons for clots is a metastatic mucin-secreting adenocarcinoma. Mucin-secreting. Mucin is a type of protein, and it can appear like clots, or if you have a compromised blood-brain barrier. So when talking about clarity, pleocytosis, by definition, is an increased number of cells in the cerebrospinal fluid. So when you have an increased number of cells, you may, when they get to a certain level, you may see a cloudy CSF. And this is associated with white blood cells greater than 200 cells per milliliter, or red blood cells greater than 400 cells per milliliter. Cloudiness can also be due to microorganisms or increased protein, which can then create a cloudy appearance. During the physical examination of urine, you need to look at the color. And the term xanthochromia is an abnormal color of CSF, and it's usually yellow, orange, or pink. And it's due to various conditions. For example, if a patient has hepatitis, it will be very, very yellow because of the bilirubin. If it's pink, it could be due to a bloody tap. It's important to report these observations out. When blood is visible in the sample, you must differentiate between a traumatic puncture and subarachnoid or intracerebral bleeding. The traumatic tap, the greatest amount of blood will be in tube 1 and the least in tube 3, because as you're drawing the sample, the blood that had pooled from this piercing will, for the most part, go into tube 1. And then it will decrease because the bleeding stops and is very slow in tube 2. And ideally, there should be no blood in tube 3 because that's what we're going to do our cell count on. After centrifugation, a colorless supernatant would indicate a traumatic puncture because all these are fresh red cells and they'll go to the bottom, versus subarachnoid or intracerebral bleeding. If this is occurring and it's consistent with a hemorrhage, then there will be the consistent amount of blood in all 3 tubes. They look identical. There's not a decrease in color from the first tube to the last. After centrifugation, there will be a xanthochromic supernatant. Because these red cells have been in the spinal fluid for a while, they of course will eventually die and they will release their hemoglobin, which then will result in coloration to the CSF. And again, it's not just in the first tube or the second tube, it's in all tubes. Macrophages may be present with phagocytosed RBCs, and macrophages may stain positive for hemosiderin and may include hematodin crystals. Moving on to the microscopic examination, cell counts. In adults, the normal cell count is 0 to 5 white blood cells per microliter, specifically lymphocytes and monocytes. So again, it's normal to have a very small number of white cells in the fluid. Red cells are not normally present. The cell counts are performed immediately to prevent lysing of the white blood cells. Lysing will slow at 4 degrees centigrade. So in hematology, if you're not able to do the cell count right away, you can put it in the refrigerator. But these should be handled stat because, again, the patient's life may hang in the balance. The cell counts are performed with a hemocytometer on undiluted specimen, counting all 9 squares on both sides. If there are too many cells, then a dilution would need to be performed using normal saline. Some hematology analyzers have been approved for body fluid counts, and these are found in your larger medical centers that have the money to pay for the advanced technology in the machine. White blood cell counts are increased in certain diseases and infections of the central nervous system, as well as a variety of other conditions. To count the white blood cells in the cerebrospinal fluid, the sample is diluted with 2% acetic acid to lyse the red blood cells. And this is because there may be so many red cells present that they obstruct your view of the white cells. So lysing of the red cells is done to help us get an accurate count. You then count the number of mononuclear and polymorphonuclear cells present and total both of those up. A differential may be performed on a cytospin slide stained with bright stain. So again, pleocytosis is the presence of cells, and there's a variety of cells that may be present in the cerebrospinal fluid. Neutrophils. What is the significance? In bacterial meningitis, up to 90% of the white cells can be neutrophils. So if you remember, neutrophils are your cells that fight off invading microorganisms. Early viral, fungal, tuberculosis, or parasitic infections can cause an increase in neutrophils, as well as some non-infectious conditions. Lymphocytes present in the CSF are increased in viral, TB, fungal, or syphilitic meningitis, particularly in the later stages. And we're specifically talking about neurosyphilis. Plasma cells. These are abnormal. You should not see plasma cells in the CSF. If they're present, they're usually indicative of a disease, multiple sclerosis, or acute viral diseases and chronic inflammatory conditions. But again, it's highly unusual to see plasma cells in the CSF. Some other cells that may be increased in disease conditions include the monocytes, and they may be increased in a mixed cell pattern such as in TB or fungal meningitis, chronic bacterial meningitis, or rupture of a cerebral abscess. Eosinophils, 10% or greater in number with parasitic, fungal, or allergic reactions. They may also be increased following the injection of radiographic contrast media or medications, and they can also result from an allergic reaction to malfunctioning intracranial shunts. And intracranial shunts are put in hydrocephalus to drain on a very regulated basis the excessive amount of the CSF. Macrophages are often found after hemorrhage in the brain because of their phagocytic ability. We need to get rid of those red cells, especially the ones that have died. Other cells, the ependymal choroid plexus or malignant cells in clumps may be seen, and you need to distinguish between malignant cells and other normal cells. Because again, in brain cancer, certain cancers of the brain, malignant cells can be seen in the cerebrospinal fluid. For the microscopic examination, I want you to spend quality time reviewing the microscopic images of cells found in cerebrospinal fluid. And these are located in your textbook on pages 250 to 253. They have really nice pictures as well as descriptions of what you're seeing on the slide. During one of the labs, or several of the labs, you will be doing microscopic examination on body fluids. Moving on to the chemical examination, the two most commonly performed tests are protein and glucose. And in certain infections, bacterial infections or viral infections, there is protein in the cell walls of these organisms. So one of the reasons we may see an increased protein in CSF is one more piece of information that there's some type of infectious process going on. Glucose, this is an indication also of microorganisms being present because microorganisms use glucose for energy. And so as they rapidly increase in number, they're going to decrease the amount of glucose in the CSF. In addition to protein and glucose, other tests may be ordered based on the condition the physician suspects, or in an already diagnosed patient, wishes to monitor. The normal CSF total protein is approximately 15 to 45 milligrams per deciliter. It's higher in infants and older adults. Some causes of an increased amount of protein in CSF is from contamination with blood during a traumatic tap. Your blood has quite a bit of protein in it, so if it contaminates the cerebrospinal fluid, then it will falsely elevate the protein. If there's a change in the blood-brain barrier, where we have a selective crossing of certain elements, but perhaps this is kind of broken and more protein is allowed in. Decrease reabsorption into the venous blood. It's a two-way street. And if there's decreased reabsorption, then this will increase the protein. And an increased synthesis of protein in the CNS. What are some associated conditions? An increased protein is seen in numerous disorders, bacterial, viral, and other forms of meningitis caused by microorganisms, cerebral infarction, hemorrhage in the brain, endocrine disorders. Multiple sclerosis is a key one, obstruction of CSF flow, and trauma. Decreased protein levels could be caused by increased reabsorption because of an increased intracranial pressure. The elements go back and forth based on pressure. Or it could be due to loss of fluid because of trauma or invasive procedures. The CSF to serum albumin index is used to assess the permeability of the blood-brain barrier. Normal values are less than 9 to 14 minimal impairment, 15 to 100 moderate to severe, and if it exceeds 100, there's complete breakdown of the barrier. So the albumin in CSF is calculated and the albumin in the serum is calculated to get the index. A typical reference interval for the IgG index in cerebrospinal fluid is 0.30 to 0.70. Values greater than this range are associated with increased intrathecal production of IgG. Intrathecal means that it occurs within or introduced into the space between the layers of tissue which cover the spinal cord, or the space between the layers of tissue which cover the brain. Values less than this range indicate a compromised blood-brain barrier. About 90% of patients with multiple sclerosis have an IgG index greater than 0.70. It's also increased in inflammatory disorders. So it uses both IgG and albumin levels in both the CSF and the blood, which the component of blood that will be tested is serum, and then the index is determined. CSF protein electrophoresis may be done, and in a CSF sample there's 4 bands that will predominate, and they're transthyretin, albumin, and 2 distinct transferrin bands. The second band of transferrin is known as the tau protein, and it is specific for CSF. Faint bands of alpha-1 antitrypsin and IgG are also possible. Electrophoresis is performed to identify oligoclonal bands that are present in CSF, but absent in the serum in multiple sclerosis, and I want you to know that. Other conditions with oligoclonal bands indicate cerebrospinal fluid protein.